markers that we use for myocardial infarction. Okay, this is a very, very easy and simple lecture, and I'm sure if you study the lecture, you will get all the questions in the exam. So you have 5 questions, I guess, in the exam, so you will answer all these questions. So make sure to, yes. Yeah, you asked me and I said yes. You are recording the lecture. Okay, so in this lecture, we will have an introduction of enzymology, so the study of enzyme, clinical enzymology. We'll explain what are the biomarkers and the isoenzymes, so biomarkers considered enzymes, and the isoenzymes. We'll explain the importance of biomarker in the diagnosis and the monitoring of the disease. And this is very important to understand this part, how we monitor the disease by measuring the biomarkers. And also, for sure, we will list the different biomarkers for this lecture that are associated with myocardial infarction. What is that? Why is Zoom? Okay. So what are the enzymes, or why we measure enzymes in the serum? We measure enzymes in the serum for diagnosis of certain disease. So this is called diagnostic enzymology. So if I have clinical symptoms for a patient that show that he has, for example, liver disease, so I check for the enzymes that are associated, that are considered biomarkers for liver disease. So it means that the biomarkers that exist in the hepatocyte and they are released when we have, for example, hepatitis. So if I suspect I have jaundice, for example, and I suspect that the patient has hepatitis, so I have to measure the biomarker that are associated with the liver disease, then the biomarker that exists in the hepatocyte, and we know that it is a viral infection of the hepatocyte. So we expect that these biomarkers are released in the blood, so we can measure them in the blood in order to see if this is really a case of hepatitis or not. So this is called diagnostic enzymology, and I will give you many, many examples on this during this lecture. So why they are released when we have a disease? Because these enzymes are present inside the cells. And when we have damage to the cell or cell necrosis, they are released and they are increased in the plasma. So we measure increased level of these enzymes in the plasma, indicate that there is a damage in the cell from where they are originated. So if I'm measuring an enzyme that usually is present in the hepatocyte, this indicates that we have problem in the liver. If I'm measuring a biomarker that exists, originated, for example, from myocardium, so I suspect that I have myocardial infarction. Okay, so depending on this, that's why we need to know these biomarkers so you can use them for diagnosis and follow-up of the disease. So the enzyme is released in the blood due to cell damage or cell death or hypoxia, intracellular toxicity, so it depends on the case. So it is, and we measure it, it's not positive or negative, it is a quantitative measurement. So we know the level. Why we need to know the level? Because the level of this biomarker reflects the damage. So for example, if I have a very mild hepatitis, so the level of the enzymes of the liver enzymes are increased. But if I have cancer in the liver, so they are much more increased. So according to the level of these biomarkers, I can tell the severity of the case. Is it a viral infection, or it's a cancer, or it is. Okay, so also the amount of these enzymes that are released from the tissues in the blood, measurement of these enzymes in the blood reflect the damage of the organ from where they are originated. So, and why it's easy to do this? Because this is a non-invasive test. You know, in medicine, we avoid the invasive procedure. So if we can diagnose the disease without doing a biopsy, so we use the biomarkers. Why we need to do biopsy? Biopsy is an invasive test. So we avoid using invasive tests for diagnosis of diseases. These biomarkers are not invasive. The measurement of these biomarkers is a simple procedure and can be repeated. And again, I repeat, repeated. This is very important, really, to know that you can measure again and again this enzyme, because you need to know the follow-up of it. So is it the myocardial infarction from the beginning? So if you measure it again and it is higher, so it means that, yeah, it is from the beginning, or if it is decreasing after a while, so it is the end of the myocardial infarction. So you can follow up the prognosis of the disease while repeating these biomarkers in blood. And this is really very important. I'll give you examples. And it is organ specific, which means that when the enzyme that exists in the liver is increased, so it is originated from the liver. When the enzyme of the myocardium is increased, so it is when the enzyme coming from, for example, the brain, so it reflects that there is a brain damage, or prostate damage, or breast. Okay, so it depends. These biomarkers are very important. But in today's lecture, we're not going to talk about all the biomarkers because we may have a lecture on tumor biomarkers. So we'll focus only on the biomarkers of the myocardial infarction. Okay. So I said that it is specific, but it's not absolute specificity, and this is very important to know. Why? Because let's say I'm doing lactate dehydrogenase. This enzyme is the biomarker for myocardial infarction, but it exists in many tissues. Okay? So I cannot take it by its own as a test to reflect the myocardial infarction because it may increase in hemolytic anemia. So it's not the case of myocardial infarction, it's the case of hemolytic anemia. But why? You tell me, okay, so why you use it? Because I will tell you about how the lactate dehydrogenase stay in the blood elevated after a while. So you can, if the patient came late, so you can use it as a marker for myocardial infarction. Okay, so it can be used in advanced or late onset of the disease, but it is not 100%, it's not specific because it exists in us. So that's why it's not enough to do one biomarkers. We need to do, I will talk about this later on. So the enzymes exist in different tissues in different amounts. So for example, we may have enzyme, like for example, aspartate transaminase, AST. It is present in the liver and it is present in the heart. So, but it is present in the heart more than in the liver. So I can take it as a biomarkers, but not by its own. I have to use another biomarkers for myocardial infarction. So we'll talk about this later on during this lecture. So what can I tell from the biomarkers, measurement of the enzymes in serum? I can diagnose a disease. I can know the organs that are involved, as I said, and I can make a differential diagnosis, as I said, because if I have, for example, I gave example, I need to know this is heart or liver, so I can tell from measurement these biomarkers. And also the extent of the disease. I gave the example if it's cancer or viral infection. Sometimes we have elevation of these liver biomarkers when you take a drug that affect the teratogenic drugs, for example, they affect the liver. So the enzymes may increase. Using the drug for the skin treatment may increase the level of enzyme, of liver enzyme in the blood. But it's not a hepatitis, it's not a cancer. So the level will be, for example, if the level should be 5, maximum 5 or 25, it will be 35, 40. But when the level is 100, 150, no, it's a viral infection. When the level is 500, no, it is a cancer. So the amount of these enzymes in blood is an indication that you have to pay attention to it when you read the results of a lab. Okay, what are isoenzymes? Isoenzymes are enzyme, group of enzymes. You know that the enzymes, they have different forms depending on their structure, on the polypeptide structure, but they all catalyze the same reaction. We've studied this in biochemistry. So isoenzymes catalyze the same reaction, they have the same catalytic function, but they differ in their, they are distributed in different tissues. For example, the isoenzymes for creatine kinase, I'll give the example, is present in the heart, it's present in the muscle, it's present in the brain. So they are distributed, the isoenzymes are distributed in different tissues, and they differ in their enzymatic properties. I'm talking here about the kinetic of the enzyme, so the Km, the V maximum are different. They can differ in their physical property, and for sure, and this is due to the biochemical structure, because we have difference in the polypeptide. So the polypeptides are not the same for all isoenzymes, but they do catalyze the same reaction, and they are very important as biomarkers because they are localized in different tissue, as we are going to see in the example of creatine kinase. So creatine kinase is an enzyme that I will discuss it during this lecture, but I'll give you just a quick example of isoenzyme, why isoenzymes are important. So it has two subunits, and we have three forms of the enzyme. So we have three isoenzymes depending on the polypeptide structure. So we can have two polypeptides B and B. So this is CK1. We may have two polypeptides, one M, one B. This is CK2, and we may have two M. So this is another type of isoenzyme. So we have three different enzymes: CKBB, CKMM, and CKMB. So they are the CKMB is present in the myocardium. So we can consider it as a biomarkers for myocardial infarction. So the distribution of these isoenzymes will help us to use these biomarkers for diagnosis of the disease depending on their tissue, from where they are originated. If it is the CKMB, so it's originated. If it is the CKMM, it is from skeletal muscle. So if you have a trauma due to an injection or any type of trauma, or you're taking statins, for example, statins may cause rhabdomyolysis. So we have myopathy due to the intake of statin. So this will increase the CKMM, not the CKMB. So increased level of CKMB is an indication of myocardial. I will talk more about the CK during this lecture. So just an example to show the importance of isoenzymes. And hopefully that I'm clear in explaining this. So please stop me if anything is not clear for you. But really, this is a very important lecture, and you need it in your clinical work. So, if I want to shift slightly to the biochemistry, I may say that the enzymes have different applications. So they are important for you as diagnostic biomarkers, and they are important also for you because they are used in therapeutic, and they are important for us because we work in the lab and we use them for the enzymatic reactions in the lab. So if I want to, for example, to measure cholesterol, I have to use cholesterol oxidase in the lab in order to measure cholesterol, because oxidizing cholesterol will give me a chromogen that I can measure by spectrophotometry. So for the laboratory, these enzymes are important because we use them for the reaction to measure certain parameters in the biochemistry lab. But for you, diagnostic, because as I said, they are used to diagnose certain diseases, enzymes. Two, they are used as for the treatment of certain disease. For example, we use asparaginase for the treatment of leukemia. We use pepsin amylase lipase for the treatment of GI tract. We use, for example, lactase for the treatment of lactose intolerance, right? So you can use the enzymes in therapeutic, and for diagnosis, measurement of these enzymes in the lab is important for diagnosis of certain disease. So we have two types of enzymes in the plasma, okay? We have what we call functional enzymes and non-functional enzymes. The functional enzymes, they have a specific function, and they are present a large amount in the plasma. And an indication of something is going wrong is when they are decreased and not increased. Why? Let's take example, blood clotting factors, for example. When they are decreased, it means that there is a problem in the coagulation. Ceruloplasmin, when it's a plasma protein, when it's decreased, there is a problem. Ferritin, when it's decreased, there is a problem. It's a protein also present in the plasma. So it can be an enzyme or it can be a protein. These are functional enzymes. When they are decreased, they indicate that there is something wrong going on. When the non-functional enzymes are the biomarkers that we use for diagnosis of the disease. They are present in very small amount in the plasma, and when they are increased, this means that there is a problem in the tissue from where they are derived from. So this means that there is a tissue destruction or necrosis from which these enzymes originate. Okay? So the plasma enzymes, when they are higher than normal, this indicates we have cell damage, cell proliferation. And when they are less than normal, this means that we have decreased synthesis or inherited deficiency. Let's talk more about this. So, the enzymes, when they are lower than normal, so it means that we have abnormal level of the enzyme, which is due to a disease, for example, inherited diseases that are, for example, the inborn error disease that we study in biochemistry, for example, phenylketonuria. The enzyme phenylalanine hydroxylase is when it's deficient, there is phenylketonuria. So deficiency of the enzyme due to mutation in the gene of that code for this protein will indicate that we have a disease. Whereas when they are increased, abnormal enzyme activity, mean that we have a disease or a trauma. So because we have damage to the tissue, and this damage will cause necrosis, and this necrosis will cause the release of the component of the cell to the plasma, and the level in the plasma is increased. So you have to differentiate between functional and non-functional enzymes. Okay, our subject today is myocardial infarction, and I'm sure you know much more than I do on myocardial infarction, but let's define the ischemic heart disease or acute coronary syndrome is a term described for a condition, range of condition that is associated with sudden reduced blood flow to the heart. So when you have reduced blood flow to the heart, you will so reduce oxygen supply, and this reduced oxygen supply will cause death of the cell, so cell necrosis, so release of the component of the cell in the blood. So, and the most common cause of myocardial ischemia is atherosclerosis. You know what is atherosclerosis? It's the accumulation of cholesterol on the blood, on the wall of the blood vessel, causing formation of plaque, and this will cause narrowing in these blood vessels. Narrowing means decreased blood supply, decreased oxygen supply, death of the cell, and cell necrosis. So, the risk factors for coronary artery disease are the following, as you know: age, gender, family history, hyperlipidemia, smoking, hypertension, diabetes, and obesity. These are the risk factors for coronary artery disease. So, what is a myocardial infarction? Myocardial infarction means that there is decreased supply to blood and oxygen to the myocardium. This will cause cell death and necrosis. So this will cause the release of these markers in the blood, and they are used for diagnosis of myocardial infarction. So the symptoms, the most important symptoms that, is chest pain. It is the most common reason for seeking medical attention. So when your patient will go to, I have chest pain, immediately you ask him to go to the hospital. Okay? Sometimes it's due to hyperacidity, but you have to ask him to go to the hospital. But this chest pain is induced by exercise, is described as pressure, it radiates to the extremity, and it is not relieved by when you ask the patient, can you rest and tell me if you feel better, then the patient will rest and say, no, it's getting worse. So this means, and if you give vasodilator drugs and you see that it's not getting better, so this means that the patient has myocardial infarction. Okay, so these symptoms, 25% of patients presenting with chest pain as the primary complaint will ultimately be diagnosed as myocardial infarction. So all the patients coming to the hospital seeking help because of the chest pain, 25% of them, they have myocardial infarction. So you will ask for an EKG, ECG. The patient, you will do an ECG for the patient. This is a normal ECG, electrocardiogram, okay, whereas this is an electrocardiogram with the myocardial infarction. So there is what we call an ST elevation here, which will indicate that there is myocardial. But sometimes you may have myocardial infarction and the ECG is normal. Okay, that's why it's not enough to do the ECG. 50% is reliable, so sometimes we have normal ECG during an acute myocardial infarction. So that's why we need to measure the cardiac markers, and also we need to take a clinical picture. So symptoms, ECG, and biomarkers, two of them you have to do in order to diagnose myocardial infarction. So why we have release of the, I want to explain the mechanism of the release of these enzymes from the cell. So when you have a myocardial infarction, so due, as I said, to ischemia, so low oxygen supply, so this will cause anaerobic glycolysis. Anaerobic glycolysis will increase the accumulation of lactate. You know, lactate is the product of anaerobic glycolysis. Then this will lead lactate is acidic, it's lactic acid. So this will decrease the pH, will increase the acidity, so it will decrease the pH. And this decrease in the pH will activate lysosomal enzymes. And these lysosomal enzymes will cause the destruction of the myocardial protein, and this will lead to cell death or necrosis, and this will lead to the release of the biochemical markers in the blood. So this will cause ECG changes sometimes, not always, and chest pain. Okay? So for sure you will have chest pain. You know very well that sometimes the pain is not as severe in patients having diabetes, so that's why you have to pay attention when a patient is diabetic and he's saying chest pain, mild chest pain, so I have to consider it as acute chest pain because patient with diabetes will sense less the chest pain. Yes. You know that when the sugar is elevated in the blood vessel, this will affect the sensation of the pain. That's why sometimes you have severe problem complication due to the diabetes, and sometimes they have it gets very serious because they have less sensation of pain due to the high level of sugar in the blood vessel. Okay, so the ideal cardiac marker, if you want to choose an ideal cardiac marker, this is for the female. You can attend. Year 3? Year 4. I don't know, they changed the classes, I'm sorry. Oh my goodness. Okay. So, I want to choose a cardiac marker that has high sensitivity, which means that even in low concentration, I can detect this biomarker. Okay, so I have the test that can show me the increased level of the biomarker, which is rapid release for early diagnosis. It helps in early diagnosis. High specificity, so it's specific for certain organ. Analytic characteristics, so I can measure it without paying a lot of money. So it's rapid test. So when you have a patient in the emergency room and you need immediately to know, you can get the results in a few minutes. Okay? So that it's very important because the quick result will help you to diagnose and start immediately the treatment. And also it has clinical characteristics. So sometimes we use a biomarker that will help us. For example, as I said, if I use the lactate dehydrogenase, it will show the late onset of myocardial infarction. I'll show you why. Okay. So what are the biochemical markers that I use for myocardial infarction? We have enzymes and proteins. So let's start with cardiac enzymes and isoenzymes. We have the total creatine kinase. Okay, it is elevated, but the specific one is the creatine kinase MB. Okay, we measure the activity of the creatine kinase and we measure the mass, the concentration of creatine kinase. We have lactate dehydrogenase LDH. We have aspartate aminotransferase AST. All these are considered as cardiac enzymes. In the protein, we use myoglobin and troponin, these two proteins that can be used as biomarkers for myocardial infarction. So let's start with the creatine kinase. Creatine kinase is the enzyme that catalyzes the reversible reaction for the phosphorylation of creatine in presence of ATP. So creatine plus ATP will form phosphocreatine with the release of ADP. So you know very well that phosphocreatine is an important storage of energy in the muscle. So the function of the muscle are performed and they require energy, and this energy is present in the muscle in the form of phosphocreatine. Creatine kinase is an enzyme that is composed of two polypeptides, so it is a dimer. So we have two monomers. We have two types of polypeptide. We have M and B. So that's why we have three types of creatine kinase that are considered as isoenzymes. So when I have CK1, it is composed of 2B, so it is CKBB. It is present in the brain, and it is important for diagnosis of central nervous system disease. CK2 is composed of one polypeptide M and one polypeptide B, so it is the CKMB. It is present in the myocardium, so it's important for acute myocardial infarction. And we have the CK3 or MM, so it is CKM2. It is present in the skeletal muscle and also in the myocardium, but the CKMB is present in the myocardium in high concentration. So, how we measure CK isoenzyme? We can use the immunoinhibition or precipitation assay, where we use antibody for the subunit M. But most modern technique, they use the immunoassay. They measure the CKMB mass rather than the activity, but this is very expensive and it takes time. So that's why we use also the activity of the creatine kinase. Now, let's define what is the CKMB2 and CKMB1. CKMB2 is the enzyme present in the tissue, and it is released in the plasma, and in the plasma, the carboxypeptidase enzyme will act on the C-terminal lysine. So it will release lysine to form CKMB1. So CKMB1 is CKMB2 without lysine. Okay, it is the type that is present in the plasma. So if CKMB1 is usually more elevated than CKMB2, the ratio should be below 1. If this ratio is above 1.5, this means that we have an onset of myocardial infarction. So measuring the ratio of CKMB2 over CKMB1, if it is elevated, it indicates myocardial infarction. It is very important when you suspect a result. For example, you will have elevated creatine kinase, while your symptoms are really not that bad and indicating myocardial infarction, and the other biomarkers do not show that there is a myocardial infarction, so it's with the CK only. So you suspect that there is a problem in the lab, and this problem is due to hemolyze the blood. So the phlebotomist is taking the blood, and we have a hemolysis, so the structure of the RBC, although the CK enzyme is not present in the RBC, but when it is released when it's released in the blood, the hemolyzed blood will have high level of adenylate cyclase. So it will transform, it will increase the activity of creatine kinase. So the hemolysis will cause stimulation in the activity of the creatine kinase due to the release of adenylate kinase, not creatine kinase. So the increased release of adenylate cyclase in the blood due to hemolysis will cause increased activity of creatine kinase. So that's why when the activity is increased and the other biomarkers do not show that there is a myocardial infarction, you have to check if the blood is hemolyzed. And if someone is working in the lab and he's a hemolyzed sample and he's measuring creatine kinase or any other biomarkers that affect the result, he should put a note for the physician, hemolyzed sample. Okay, hemolyzed sample. So the doctor has to think about if he can take the result or should repeat the result. In most cases, we have to repeat the result, the test, because this is not a reliable result that we can take it. These are the ranges of the creatine kinase. They differ a bit between male and female due to the muscle, as you know, mass. The CK and B usually should be less than 6% of the total concentration of TK. And if it is elevated, this means that we have myocardial infarction. So the CK MB is more specific than CK, than total CK, because it's specific for the myocardium, but it is less specific than another biomarker, which is the protein troponin I, because troponin I is more specific than CK and B. Why? Because CK and B exist in the muscle also, so that's why we have to pay attention in order, that's why we don't take on biomarkers in order to diagnose a disease. So it appears in the blood. What is important about this biomarker, so you tell me, okay, why we use it? Because it appears in the blood 4 to 8 hours after the onset of the myocardial infarction, and this is very important. You have to know what are the biomarkers that you measure in the lab, because it happened to me. I had my father, Allah yarhamu, I took him to the hospital, and they measured, he had a myocardial infarction, and it was a late onset, it was a very early onset. They measured the blood even 1 hour after the onset of the symptoms, and the results came out negative, and they asked him to send him home. So this is very early. I cannot measure the CKMB. I know that the onset, it will increase 4 to 8 hours. 4 to 8 hours. So if I say that the patient has symptoms after 1 hour, this means I can't measure this biomarker. So you have to pay attention when to ask for the measurement of the biomarker. And you cannot send your patient home if you are measuring the biomarker very early, so you cannot get an elevated creatine kinase. So you have a peak of creatine kinase 12 to 24 hours after the onset of the myocardial infarction, and it returns to normal 2 to 3 days. So it will no longer stay in the blood, and this is the disadvantage of these biomarkers. So if there is a late onset, you cannot detect or diagnose the presence. That's why you have to use another biomarkers, as I will show you in a minute. So the advantage is useful for early diagnosis, and it's useful for diagnosis of reinfarction. So if you have one infarction that is followed by another infarction, sometimes you have recurrent infarction. So when you see that the level is increased, then it will increase so another infarction. So creatine kinase, MB, is important for diagnosis of early diagnosis and for of myocardial infarction, early diagnosis of myocardial infarction, and for re-infarction. So this advantage, as I say, that when you have delayed admission more than 2 days, it cannot be used. So, for example, if I have a patient coming to the hospital, admitted to the hospital, saying, 2 days ago I felt chest pain. Oh, come on, you cannot ask for CKMB. Okay, you have to ask for another biomarker that I will show you. And it's not 100 specific because, as I said, it is elevated in skeletal muscle damage. So that's why you have to use another biomarker. So we use also CKMB mass. It appears 1 hour earlier, so I can take it. It's more sensitive, and it's useful for early cases, but not for delayed admission, as I said, and it is less specific again than troponin I. So we can use also the index MB, we call it relative MB index, which is the CKMB mass over the total CK times 100. This, when it is more than 5%, this indicates a myocardial infarction. So I can do this also, because as I said, also the CKMB form, when it is more than 6% of the total CK activity, because it should be less than 6%. If it's more than 6% of the total CK activity, so this indicates also myocardial infarction. Okay, enough concerning CK, creatine kinase. Now let's move to another biomarker. It's lactate dehydrogenase. You know the enzyme lactate dehydrogenase catalyzes the reaction, the formation, the reversible reaction for the formation of lactate from pyruvate, which is the last reaction in the anaerobic glycolysis. So the enzyme is present as isoenzymes in different tissues, and it consists of 4 polypeptides, and we have 2 types of polypeptide. We have H and M, so that's why we have lactate dehydrogenase 1, which is composed of 4 H polypeptides. We have lactate dehydrogenase 2, and 1 exists in the heart and kidney. We have lactate dehydrogenase 2, which is composed of 1 polypeptide M and 3 polypeptide H. We have lactate dehydrogenase 3, which is composed of 2H, 2M. We have lactate dehydrogenase 4, which is composed of 1H, 1 and 3M, sorry. And we have lactate dehydrogenase 5, which is composed of 4 M polypeptide. Now we'll ask you, do we need to know all these details? What's important to know actually is the 5, okay, and the one that exists in the skeletal muscle, and the one that exists in the heart, which is lactate dehydrogenase 2. So lactate dehydrogenase 2 is considered as a biomarker because it's present in skeletal muscle, in cardiac muscle, in renal tissue, and in RBC. The plasma activity of LDH is elevated due to liver disease, due to cancer, due to acute myocardial infarction, due to metabolic disease. So what I can say about this biomarker, it is not specific. It is increased, but it is not specific. So I use the lactate dehydrogenase. Sorry. Oh yeah. So I use the LDH1, which is composed of 4 polypeptide, 4H polypeptide. It is present in the heart and the RBC, but again, it's not specific. So if I have hemolytic anemia, so if my sample here is hemolyzed, it will increase the level of LDH without having myocardial infarction. Okay, so I use also the lactate dehydrogenase 5, which exists in the muscle. So the isoenzyme for cardiac is lactate dehydrogenase 1. Okay, LDH1 is a biomarker for myocardial infarction. So why it is important to measure it, although it is not specific? Why I don't choose another biomarkers? Because it increases 12 to 24 hours post AMI, so I cannot use it for early diagnosis. It peaks at 48 to 72 hours, and it remains elevated for 10 days. So if my patients came to the hospital saying that I had chest pain 2 days ago or 3 days ago, and that maybe it was an infarction, it passed, but it was an infarction, so I have to know, so I have to ask for lactate dehydrogenase in this case, because this is for late diagnosis. So as I said, it is it may be normal for 12 or more more than 12 hours. So that's why I cannot use it for early diagnosis. It may not detect minor infarction because it is not very sensitive. And the RBC, when they are hemolyzed, so it's increased in the blood, so it may cause false positive result. And the normal level of lactate dehydrogenase is 100 to 225 international units per liter. So these are the disadvantages for lactate dehydrogenase. Actually, the most important advantage of lactate dehydrogenase is that it stays in the blood for days. So, yes?
Do we consider lactate dehydrogenase 2 as a biomarker?
No, one. I made a mistake when I said two. I said two before, right? Yeah, no, it's one. Okay? So look at this electrophoresis. We do it for lactate dehydrogenase, but actually we can't do it because it's very expensive. No need to do the electrophoresis in order to quantify the isoenzymes. So you can see but how the in myocardial infarction, the LDH1 is increased. So this is an abnormal lactate dehydrogenase increase, which is due to myocardial infarction. Other enzymes that we use for as biomarkers for myocardial infarction are the transaminase enzyme. You know, we studied in biochemistry, we have two types that we studied that they catalyze the two reactions. One is called aspartate transaminase or aspartate aminotransferase, and one is called alanine aminotransferase or alanine transaminase, ALT and AST. So this one is specific for the liver. Actually, the ALT is one of the liver function tests, whereas AST is present in the heart. So we consider it as a biomarker for heart, but it is, again, it's not specific. So I cannot take the AST alone to measure these two enzymes are both present in the liver. So that's why when the increase of AST, it doesn't indicate. I cannot take it as a biomarker alone for measurement for diagnosis of myocardial infarction. So in viral hepatitis, they are increased. ALT increase is specific for liver damage because it's present in high amount in the liver, whereas AST is moderately increased in muscular dystrophy and acute myocardial infarction. So it is a biomarker for myocardial infarction, but I cannot take it for diagnosis. So we have high concentration of AST in skeletal muscle, in cardiac muscle, in liver tissue, in lung tissue. You can see it's not specific. But when we consider it for acute myocardial infarction, it rises 6 to 8 hours. It peaks at 24 hours, and it returns to normal by day 5. So here, for sure, we prefer creatine kinase or the other protein that I will discuss now. Myoglobin is a protein that can be considered as biomarker when it's elevated in blood. It's a marker for myocardial infarction. It is a soluble heme protein. It is present in all muscle cells, cardiac and skeletal. The plasma myoglobin is elevated due to muscle damage, due to surgery, due to severe exercise. When you have severe exercise, due to the muscle disease, due to physical trauma. So it is increased due to any damage that occur in the muscle. Myoglobin can be elevated also from decreased renal clearance because it's small molecular weight. So if you have decreased renal clearance, it will be increased in the blood. It is a relatively low molecular weight. It is soluble in water, high cellular cytoplasm concentration. So we can consider it as biomarker for cell damage. Troponin I is another protein that we can use it for as a biomarker for myocardial infarction. It is present in the skeletal and cardiac muscle. We have two forms, I and T. The troponin I is specific for cardiac tissue. We have also troponin T. So we measure both troponin I and troponin T. But we use I as most specific for cardiac injury. So troponin I is more specific than troponin T. So these are proteins that exist in the muscle, and when we have damage to the muscle, they are increased in blood. C is also a troponin present in muscle tissue, but as I said, the I and T are present in the heart, so we can consider them as biomarkers for myocardial infarction. What is important about troponin that they have high specificity. So that's why we use troponin. As I mentioned before, Creatine kinase is not highly specific, but it's used for early diagnosis. Lactate dehydrogenase is not at all specific, but we can use it for late diagnosis. But this marker, troponin, is specific for the heart, and it can be used better than the other biomarkers. I want to mention here the beta-natriuretic peptide before I move to the different. Before I move to to show you the difference between all the biomarkers that we explained. So the beta-natriuretic peptide is an important biomarker for congestive heart failure, not for myocardial infarction. Okay, because it is released from the ventricles when you have congestive heart failure, and can be considered as a marker for congestive heart failure. So we have a drug which is a synthetic recombinant of human beta-natriuretic peptide, lisariside. It's used for treatment of congestive heart failure. So natriuretic peptide is not a marker for myocardial infarction. Okay, let's skip this because I mentioned this. Okay, quickly I want to move to the cardiac enzymes. So as I said, CKMB is used for early diagnosis because it peaks 3-4 hours after the onset of the myocardial infarction. The total activity is also increased, okay? But the CKMB is more specific for the myocardium. We have also the AST, but it's not specific because it's present also in the liver. And we have the lactate dehydrogenase, which is the biomarker for late diagnosis. You can see remain in the blood days. So, but it is not specific. So, we have what's called a triage. Triage means that we have three. It's a commercial test that use 3 biomarkers for the diagnosis of myocardial infarction. We use myoglobin because it is for early diagnosis. Also, we can use troponin, which is specific for myocardial infarction, and the total CK also, the CKMB can be used for myocardial infarction because it's specific for the myocardium. So, first we have myoglobin, followed by increase in troponin and by CKMB. Okay, these are the 3 biomarkers that we can use for diagnosis of myocardial infarction. The lactate dehydrogenase can be used for late diagnosis. So you can see the level here, it increased myoglobin. So it's very sensitive because it increased 2 hours. It has a peak 6-8 hours, and it's back to normal after 36 hours. Troponin 4-8, peak 16. We have also, it is considered as for late diagnosis, it will stay in the blood like the lactate dehydrogenase, but it's more specific than lactate dehydrogenase. The CKMB peak same as troponin, and it's remains 2 days in the blood. It has a peak 2 days, and then it remains 72 hours in the blood. So what I can tell here, that myoglobin can be used for very early onset, okay, but as again, it's not specific. Troponin is specific, it increased after 4 hours, and CKMB is somehow specific, and it increased after 4 to 8 hours. We have other biomarkers for myocardial infarction, which is the myeloperoxidase enzyme. It is a marker for inflammation and oxidative stress, and it's produced by neutrophil, monocyte, and endothelial cell. It is elevated when we have atherosclerosis. Okay, so it can be considered as marker, but we don't consider it for diagnosis of myocardial infarction. So here, this slide summarizes everything. Myoglobin first comes and first goes. Lactate dehydrogenase is called the lazy enzyme because it comes late and goes late. Troponin I has the greatest sensitivity and specificity, so it's the best biomarkers, troponin I. Also we use CKMB because it increased after 4-8 hours and specific for myocardium. So the CKMB is useful for the confirmation of, as I said before, of reinfarction. Okay, we can use CKMB for reinfarction. So if the patient comes after 72 hours of initial infarction and you are suspecting a reinfarction, you go for CKMB. So when you want to detect a reinfarction, you use CKMB. When you want to detect a late diagnosis, you use LDH. So myoglobin disappears 24 to 48 hours, CK and B disappear after 72 hours, troponin I disappear after 7 to 10 days, and LDH disappear after 14 days. So what if I ask you in the exam, which of the following for late diagnosis of myocardial infarction, and I included LDH and troponin I, and then I add specific.
Troponin.
So late and specific troponin I. Okay? So let's take one scenario. CKMB of the patient is normal, troponin I is raised. He is 3 to 10 days post myocardial infarction. Okay, when you have normal CKMB and elevated troponin I, so this is a late diagnosis, 3 to 10 days post myocardial infarction. Scenario 2, CKMB and troponin I are normal, LDH is raised, he is 10 to 14 days. Okay, because the LDH will stay more than troponin I in the blood. You have here a case study of a patient, 63-year-old male, brought to the emergency department, having chest pain, that they lasted for 2 hours. Okay, so you pay attention to the 2 hours. He had removed his lung when the pain developed, and he became concerned when the pain did not subside after he stopped the activity. So he had no previous history of heart disease. On presentation, he was moderately overweight, diabetic, and in obvious discomfort. He described his chest pain as beginning in the center. It's very important how they describe the chest pain. Beginning in the center of the chest, then moving to the arms, neck, and jaw. This is typical symptom of myocardial infarction. So, what is the most important consideration in the triage of the patient?
Stay in the hospital.
Myoglobin, troponin, creatine kinase. What test should be ordered? So, myoglobin, because 2 hours, so early onset. Okay? What is the most important consideration in the triage of this patient? What do you have to consider in this case? In this case. So, what was important? Yeah, the chest pain indicate that these are the symptoms of myocardial infarction. But what is important in this case, 2 hours timing. In your case study to diagnose myocardial infarction, timing of the incident. This is the first question that you have to ask the patient. How do you feel? Describe the pain and when it started. Okay, it's very important to ask this question. Okay, is it a difficult lecture, I guess? No, it's very easy, very important. Yes?
You mentioned that adenylate cyclase is a false indicator.
I can't hear you.
You mentioned adenylate kinase as a false
Yeah.
indicator of creatine kinase.
You want me to re-explain this?
Yeah, like how do I know when I should repeat the
Okay.
sound?
If I'm getting a result that I suspect the result, for example, the CK is normal while the other tests are elevated. Sorry, the CK is elevated while the other tests are normal. So I'm measuring troponin, myoglobin, and CK. Okay, if CK is elevated and troponin and myoglobin are normal, it's weird, no? So we have to check if this CK increase is due to a false result. For example, a hemolyzed sample. If there is no hemolyzed sample on the result, you have to call and ask. Or it can be due to a trauma in the muscle. It's not myocardial infarction because the other biomarkers are normal. So in myocardial infarction, one test is not enough. And if you have to choose one test, and it is an early onset, if you want to choose, regardless of the timing, if you have one test to do, if I ask you, you have one test, tell me which one you use for myocardial infarction, what will be the answer? Troponin I.
Doctor,
Yes.
can you share example how to detect reinfarction? Yes.
Yeah. If, for example, I'm measuring CK and B and the level is elevated, then I repeat it, it's decreased, then I repeat it, it's elevated.
Oh.
So this is a reinfarction. Because we know that CK and B decrease after hours. And when you see it increasing again, this is a reinfarction. So that's why we use it. Because it decreased and it increased. I cannot wait days for LDH and then I measure again LDH. LDH is not for reinfarction because it's remained high. So to decrease, and I will have to wait the level to decrease, and I ask for another test. No, it's very late. So the CKMB, because it starts early and it decreases quickly, so another increase means a reinfarction.
Thank you.
Okay? Wish you a, because it's my only lecture, I guess, for you. So good luck in the semester, third year. You made it, so you will be a doctor for sure because you are a third year student. And hopefully it will be a very successful semester. Thank you. Do we need to take attendance?